So welcome to Family Caregiver Workshop. I'm Sarah Hatch. I'm one of the social workers here at Sanders Brown. We do this workshop with the Alzheimer's Association, so Meredith Plant is back there, and the Bluegrass Area Agency on Aging and Independent Living. And Regina is here with that organization. We're going to cram a lot into 2 hours. Typically, this workshop is 3 hours, but we've truncated it today. So we will be moving pretty quickly through things. If you need a restroom break, we'll have small breaks as we transition presenters. The restrooms are here in the center hallway, and feel free to get up and excuse yourself and then come back. All of our material, all the slideshows, we will email out. For those who are virtual, we will be emailing everything out. So the handouts that people here have in front of them, we'll be emailing those out to you as well. We are recording this presentation, so we will also be posting that online. So if there's an objection, please let me know. You here in the room will be visible on the recording. So with that, let me switch to So today what we're doing is we've called this our holiday edition. So we're going to talk about just kind of navigating holidays with a dementia diagnosis. What does that look like as a caregiver? And then we kind of will go into some of our other caregiver information. Holidays bring a lot of different things. There's excitement, there's joy, there's lots of memory making that can happen. But with holidays also comes stress. It comes a lot of unfamiliar faces. It can be really noisy. Our schedule, our routines get mixed up. There can be travel. So there's a lot to try to navigate and go through. So we're gonna talk about that quickly. So one of the biggest things, which I know is hard to do, is be patient and flexible. Be prepared that with all the changes in schedule and the different activities going on, you may see changes in mood and behavior. So kind of try to be prepared for that with ways to distract or things to do to try to help soothe the different changes in mood and behavior. Our expectations in holidays, sometimes we can visualize things in our head to be this perfect, glorious layout. Sometimes we need to just kind of lower our expectations a little bit and be realistic. Know that we have a lot on our plate that we're doing and dealing with. So it's okay if we ask people to help us. It's okay if we decide to have somebody cater our meal or use paper plates. So be realistic about what you can do and then be willing to accept help or ask for help for other things that you might need. An idea that can be helpful if you've got a lot of family coming over or if you're going to family is ahead of time, provide a little update. So through an email, a call, a text, kind of let them know what's been going on, especially if they haven't seen their loved one in a while with memory problems. Kind of let them know either, hey, they expect a lot of the same questions to be repeated. And here's how I handle it. Either I distract or I say, yep, I answer that question. Remind them, don't say, I already told you that. So kind of give them a little heads up on what to anticipate and kind of how to handle some of those things to make everything a little bit smoother. Think about, you want to maximize the time of day that your loved one is the most active and alert. So that's different for every person. So it might mean you have a Thanksgiving brunch or a lunch instead of a dinner. It might mean you have a dinner instead of a lunch. So you want to think about your loved one and when they're most alert and active and kind of try to maximize that time. If they're prone to sundowning, which is that evening time when it's getting to be dusk, a lunch is probably a better idea just to kind of help avoid some of that confusion. And then just a reminder for all of us that activities come with a lot of different things. And so your loved one will be exhausted. You'll be exhausted. So remember that it takes a lot of energy to navigate new faces, new routines. So be mindful of that. Don't plan back to back activities. Make sure you build in some rest time, maybe a day in between activities for recovery. And then being mindful, holidays, again, we bring lots of family together, so our gatherings can get really large sometimes. Be mindful of that. If there are ways to maybe have smaller groups, that can be sometimes helpful. Sometimes it's having multiple ones, or if you have all the family together, think ahead of time, is there a quiet spot or room that loved one can go to if it becomes overwhelming? A lot of times in large groups, big tables like this, a lot of crosstalk starts happening, and it can get really confusion on who's saying what story are we talking about. So it can be a lot to keep up with. And so you'll see your loved one either withdraw some or just get frustrated with it and want somewhere to go. A lot of times there can be kids running around. It can get crazy and chaotic. So having a safe space when you kind of pick up on some signals that they're getting a little overwhelmed, maybe say, hey, let's go visit in this room for a few minutes, or let's go on a walk if the weather is decent, to give them a break. Ultimately, we want to simplify some of our holiday activities. So what we want to do is focus on what they can do and kind of keep that in our forward mind. There's a lot they can't do. Our traditions may change, they may look different, but we want to focus on what we can do. So if that's watching old Christmas movies together, if that's singing songs, maybe you used to go to concerts and do other things, but maybe as a family you can sing some songs together. Music can be a great way, or just listen to music. Music can be a great way to relax. It can connect. It's in a different part of our brain, so sometimes we connect to those songs from long ago much quicker and easily. Maybe they used to decorate the outside of the house and do all the decorations. So maybe this year you take a car ride and you go tour your neighborhood and look at lights together. Maybe they were the ones who cooked the meal. Maybe there's now a few steps they can help with: washing vegetables, or getting the dishes ready, helping decorate the table. If they were a big shopper before, maybe now they can help wrap some of the gifts. So finding ways to keep them included and involved in the activities is always important. And of course, safety, we don't want to forget that. A couple of things: think about your decorations as you're putting them out. A lot of times we do have a lot of flashy things, blinking lights. Sometimes we have candles. So we want to be mindful of that. Flashing lights can be really disorienting. If there's a ton of decorations up and you transformed your rooms into something completely different, that can be disorienting. They may not know where they're at. So trying to keep decorations simple. Also be mindful of decorations that look like food. Especially at Thanksgiving, we see lots of decorations of pumpkins and gourds and apples and things like that. If it looks real, they may want to take it and try to eat it. So be mindful of that. When you're visiting friends or family, you want to kind of double check, make sure cords are out of place. With all the lights, some extra cords, so be mindful of trip hazards. And also be mindful of wandering. Your loved one may never have wandered before, but when you go into a new environment that they're unfamiliar with, and there's a lot of other things going on, they may try it again, seek a place that's quieter. So they're not really wandering away, but yet they are, because you haven't seen them leave. So just being mindful of that, kind of having somebody who can kind of keep an eye on them. Maybe it doesn't need to be you, it could be another loved one. Say, hey, just kind of keep an eye and help me make sure we know where grandpa is. And then again, we'll talk about this a little bit later, but keeping in mind of their physical needs. So are they hungry? Our schedules change again, so maybe we're eating lunch later than before, so maybe they're hungry. And so some of their behaviors could be hunger, could be thirst, could be needing to go to the bathroom. Again, new locations, don't know where the bathroom is. They may be confused and been holding it for a while. So just kind of checking through some of those basic physical needs, especially if you start to see behaviors that you don't understand or that are not normal. And then kind of some gift ideas for the holidays. And this is also in your folders. We want to be mindful and tell family not to get gifts that are too complicated. So kind of sticking to some more simpler things. So sometimes GPS trackers can be helpful, especially if someone loves to walk, and that can be a wide variety of things. It can be on keychains and wallets and shoes. They make lots of different types. Fuzzy blankets, weighted blankets can be very soothing. Different types of music. Again, I told you music can really do a lot with connections and things like that. So there's a lot of different music players out there that can be set up. Subscriptions to magazines. Sometimes getting mail can be exciting. Something to look through, navigate. Photo gifts. So this is a memory card game with family photos, but you can make calendars that are personalized where you can put birth dates and anniversary dates into the calendar with pictures. You can make memory books. So there's a lot of different options around photos. And gift cards are another great gift because that allows them some independence to go and spend some money and do something they want to do. One other thing that's not on here is sometimes experience. Experience gifts are really big right now. And so it's saying, hey, let's take the day and let's go do something together. Maybe it's go look at a horse farm. Maybe it's go visit a park. whatever they love to do, making that an experience and giving them some of your time to share can be a really impactful gift as well. I leave with this season, try to focus on things that bring you happiness and joy by working to let go of activities that can be overwhelming, be stressful, or risky. Something for us all to try to do. Again, I know it's not as easy as it says, but it's something to kind of work towards. Does anybody have questions? I know I just threw a lot out really fast, but. Well, we are going to transition here real quick. We have Dr. Bojarski here, who is our fellow here at Sanders Brown Center on Aging. And so she is going to come and share with you guys. Let me get her.
Thank you, Sarah. I appreciate you sharing. I like the little present at the end. I can't figure out how to do that on PowerPoint, but love it when other people can. So I'm Dr. Bojarski. I'm the geriatric fellow this year. For those of you who don't know what a fellow is, it basically means that I've done all of my residency training. So I am a licensed physician. Once I pass my boards, I've already taken my boards, I'm just waiting for the results. So we're fingers crossing that we pass. But ultimately, I'm a neurologist for all intents and purposes, and I'm just asking for an extra year to learn more about our geriatric population. That includes the aging population, that includes people with neurodegenerative problems. And specifically, it has to do with people with Alzheimer's or other dementias. And please excuse me, I have a mitt in my mouth. It's almost gone, but please ignore the weird slurred speech sometimes. So when we talk about the brain, we're going to talk first about how we map the brain. So when you come in with a loved one or you yourself, and you want to know why your brain isn't working the right way, this is how we view the brain. And we give you tests and labs in order for your brain to talk to our brain to tell us what's wrong. So in order to do that, we have to map it. And we organize it into different ways. So this is like if my brain like this was superimposed on this slide. So this is the front part of our brain. This is the frontal lobe. This has to do with thinking, memory. It also has to do with coordinating behavior and some movement. In the back here, we have our parietal lobe. So right back here, this orients us into like space and time. So it's kind of how my brain can coordinate that I can touch this and know that I'm touching it. Like a map is how I map my world. Temporal lobe is a lot of hearing, right? Our ears are right here. So the temporal lobe is where we hear a lot of different things. It's also really important for learning. So, you know, our patients with Alzheimer's might have a little bit less temporal lobe function than a normal aging population. So that's something that we tend to focus on. The occipital lobe is back here. And ironically, this is how our brain sees. So our eyes are already here at the front, and there's tracks that go all the way to the back. And this is where our brain interprets what we see with our eyes. We have our cerebellum, which is underneath here. And this is what, if this gets injured, this is why some people have that drunk walk. So that's what you can think of the cerebellum functions in. It kind of keeps you stable and keeps you level-headed with the world. And then you have your brainstem, which all of this evolutionarily grew on top of our brainstem. So our brainstem is the most basic of all of our functions: breathing, heart rate, stuff like that. So those are all really important things to understand in the broad context of how the brain is mapped. I wanted to tell you some definitions as well as we go through this discussion, because I think it's really important. Because a lot of people are like, oh, well, they have Alzheimer's and then they have dementia. And some people think that they are the same, and that's not necessarily true. And I'll go into detail why that is. So cognition in general is the mental action or process of acquiring knowledge and understanding through thought, experience, and the senses. Mild cognitive impairment, you might have heard that terminology before. That's when you have cognitive decline, but you're still able to function independently. Meaning, oh, I might have some memory problems, but I'm able to compensate. I make lists. I'm not missing my doctor's appointments. I'm still managing my medicines. Might take a little bit longer than it used to, but I'm still overall independent. And in dementia, it's an umbrella term. Dementia is when we have such cognitive decline in one or more domains. So remember, we had mapped out the brain on the slide before. You can have problems in your memory, your language, attention, the mapping functions that we talked about, and social behavior, but it needs to impair your daily functioning. So when we have someone who comes in with a concern for dementia, they're getting to the point where they can no longer manage their finances. They're getting to the point where they can't quite take medicines by themselves because they might take 2 of one, they might forget to take them another time. They're needing help. And that's kind of that delineation between a mild cognitive impairment and a dementia. The reason why we say dementia is an umbrella term is because we want to know why. Why do you have a dementia? And that was all the little teardrops of Alzheimer's, frontotemporal, et cetera. So when we talk about the progression of, we'll say Alzheimer's, it's usually dementia in general, but for this particular paper that I found, it was Alzheimer's. Typically, and I don't know how familiar you are with statistics and graphs, so I'm going to tell you what to look for. So there's this x-axis down here. This is the amount of years. So it increases in years the more right you go. And then cognitive function, you're high in your cognitive abilities, like you have good reserve, you're functioning day to day. And obviously, the more you go down, that's less cognitive function. And so over time, normal aging, our cognitive function is pretty good. We're chugging along, we're doing our stuff, we're living our life, but it never gets to a point where our brain is decompensating. It's never getting to a point where we would have issues with just functioning daily life, like forgetting to eat and stuff like that. When we have aging with disease, that's all here. And we can see, even as far as when you're fairly cognitively normal, we can see in the preclinical stages in some of our research that the Alzheimer's brain will start to degrade over time. Even before symptoms can show, we can sometimes see things on the MRI. We do some studies now with lumbar punctures that can show us that there might be some evidence of some ongoing neurodegenerative problem even beforehand, but that's still in research and we're still working it out. But just to let you know, that's where the future is going. We can find preclinical problems with some of the research we do. A lot of participants, patients, whomever, family members come to us in the mild cognitive impairment category, where the brain is still compensating for changes. Like I said earlier, you're having mild cognitive impairment, you're noticing that you're maybe forgetting things a little bit more, so you're making more lists. You're maybe making sure that calendar is extra accurate because you're forgetting doctor's appointments, and but you're compensating. So you're still able to keep up with the degradation of what's going on. And then dementia, like we said, leading to a loss of independent function, and then ultimately having that dementia diagnosis. When we talk about Alzheimer's disease, that's the most common one. That's the one that we like to talk about the most here. It's typically episodic memory that's the first to go. So when we talk about temporal lobes, that's where most of our memory is located. When we have problems like missed appointments, forgetting conversations, repeating yourself in conversation, forget having done something, that can be concerning for a memory problem, right? It progresses to things like getting lost, wandering, decreased work performance, word finding difficulties. And these are all things that we just know to happen as the disease progresses. We also know that we can find pathology in the brain when we have an Alzheimer's diagnosis. So we have a couple pictures here. This is a gross specimen. This is actual like histopathology when we do autopsy of brains. We see neurofibrillary tingles and neuritic plaques. Those are the things that build up in our brain that contribute to the Alzheimer's presentation of the symptoms they have. And then this is a fancy looking one that Kelly had that I wanted to keep in because I thought it was really pretty. But you can see the healthy cells, they're synapsing, they're plump, they're juicy, they extend, they look great. But all of these plaques have now inhibited all of those neurons from talking to each other and presenting those symptoms. So that's what happens with Alzheimer's. They're not able to function as well as they used to. A lot of times I get a lot of concerns of, I don't know if this is normal aging, and I don't know if this is something that's bad. So I have a list of a lot of questions that a lot of patients, participants, caregivers, loved ones have, and they're like, okay, well, I'm forgetting the name of people I just met. Well, that's normal. I do that too. That's okay. But what's bad is if you can't remember your family members, or you worked in a hospital for 20 years and you worked with this one social worker every day, all day, and you can't remember their name anymore, that's a bad sign. Things like writer's block or occasional word finding difficulty, we all have that. I can't tell you how many times I've had that too. But when it gets to the point where it's interfering with you functioning, like you cannot convey yourself as well, that's a little bit of a concern there. So I believe these slides are getting
Yeah.
sent out, so you can go back and look at these. We're not gonna go through all of them today, but just noticing that there's a spectrum of it. If it's a little subtle, that's okay, but if you're noticing that it's getting worse, that might be a time to let us know. When we evaluate for a suspected dementia, cognitive problem, anything like that, I'm really proud of this smart art, but we ultimately get a consult for the memory complaint. So say you or whomever go to your primary care and you say, I have a memory problem. They say, okay, I'm sorry to hear that. Let me ask you a couple questions, maybe do a couple screening things, and I'm going to refer you to our memory care specialist. That's when you come to us. When we see you, we evaluate your neurologic and cognitive function. And if we feel like it's necessary, then we'll order imaging and labs. And we'll go over details of this in a little bit. That might add on a little bit more testing of your brain. Think of it like a third grade exam on steroids. You're basically taking 3 to 4 hours of testing, and it tests the different mapping of your brain that we talked about earlier. It tests different parts of it. And that's just by us asking you questions, we can get a lot of information. So that's something we might consider. At that point, we establish a diagnosis of normal mild cognitive impairment or dementia. And then that's when all of the other things happen when we decide, okay, what's going on? Because that, after we've defined what type of dementia, what's the etiology, why, then we can treat it. And we can treat the related symptoms that we know evidence-based medicine has told us will help with that presentation and that pathology. What are barriers to diagnosis? Well, a lot of people say, oh, I thought it was normal aging. I thought that I was fine. I thought that, it was just something that happens. Other barriers can be that evaluation can be unattainable. Sometimes our wait list is up to 9 to 10 months to see us, and that's a long time. And we know that, and we're trying to fix it, but there's just not enough of us geriatric neurologists to service the population. So we're actively trying to go into the community and ask for more money to fund positions like mine. So that's all really important things. Evaluation can be time consuming. Our visits are typically an hour, but honestly, they typically go for an hour and a half. If there's concerns for safety and other things like that. And that's something that we want to make sure that everyone is safe. And that requires more discussion because we want to give you resources and stuff like that. So it can be time consuming. Transportation can be an issue. Getting here, we understand that as well. Also, the last thing I wanted to mention about barrier is just that a lot of people still are under the impression that Alzheimer's diagnosis can't be made unless it's an autopsy, or that it can't be treated, and that's just not true anymore. As of July of 2023, we now have an FDA-approved medicine that in some specific patients, which I'll go into in a little bit, can slow the progression of the Alzheimer's. It's not a cure yet, we're still working on it. But at least we have something now, and it's a good jumping off point for us to move forward with our research, and that's where our research is now. What can we do to further these studies and further these medicines so that we can get on the road to a cure? We're so close. Not there yet. So what does a cognitive and neurologic exam look like? These are examples of cognitive evaluations that you would get here in our office. I'm a fan of the MOCA. Primary care physicians like the MMSE, and Dr. Jika likes the short test of mental status. Different people have different ways of examining the brain. They all pretty much say very similar things. They're trying to map where the problem is in your brain. For example, if you have an Alzheimer's problem, it's going to be more here and here. If you have a frontotemporal dementia, it'd be here and here. And the way we ask our questions can kind of help us guide where that would be, where the problem is. And then a neurologic evaluation, we're looking for Parkinson's, we're looking for strokes, we're looking for other etiologies of what might be underlying the problem. What kind of labs might we draw? A lot, but not enough to suck you dry. We usually do a complete blood count that tells us things like, how is your hemoglobin? How are your platelets? Are you at risk of having too low platelets and you might bleed, or things like that. A complete metabolic panel tells us about your electrolytes and how you're functioning there. Do you have kidney disorder? Do you have an elevated molecule in your brain that makes you have brain fog? That's how we're going to look at that. So these are all reversible things. These are labs that can help us look at reversible things that we can change on the flip side once we know about them, and that can help with your memory. So these are absolutely you don't want to miss things. That's why we get them on pretty much every patient, not pretty much every patient. The apps that also will include B12 and folate. Sometimes thiamine, sometimes other specific things. If we talk to you and we get a vibe that maybe one mineral might be off, or if we get a sense that there might be something related to your medical conditions, we might add on from that. But these are the basic ones that we'll get. And then a thyroid panel as well. We make sure that everyone in this office has the best thyroid, because we are making sure that everyone has good TSH levels. If we decide it's important that we need to get CSF, this is what it looks like. I think people are always surprised when they see what CSF actually looks like. This is cerebrospinal fluid. This is the fluid that, the brain that we saw earlier. This is fluid that bathes the brain. It cleans it every day and it recycles and it gets made new. And for this, we want it to be clear. It looks like water, basically. We want it to be clear. But this is what we would use to test if you had Alzheimer's. If we were suspecting based off your cognitive testing and your physical exam, if we're concerned you have Alzheimer's, we would do a lumbar puncture. Think of it as an epidural that a pregnant woman would get, but instead of putting in anesthetics, we're just taking fluid out. It's the same process. Different space, but same process. This is how we're going to see for Alzheimer's. If we're concerned you have an infection in your brain, this is something that we would offer as well. So the most common imaging modalities that we get are here. There's 3 of them that are the most common. Y'all have all heard about the MRI, and here I've even shown, we were talking about temporal and parietal, like here and here, misfunction with Alzheimer's. This is a brain. It's as if you were looking at a picture, like a slice down me. So this is the top of my head, and this is the side of my head. This is left and right. And as you can see in this healthy, it's really plump, it's really juicy. There's not a lot of big black spaces. But in here, it's not as plump. It's not as juicy. I see a lot more black. I see more black here, here, and even here. These are where our hippocampi are. The hippocampus is in charge of helping us learn new things. And they get really tiny with Alzheimer's because we're forgetting things. That's the whole point of Alzheimer's. So we know that these can be affected and are affected, and then it typically grows out. So we were talking about how the brain likes to eat glucose, and so it'll show up really bright and shiny and red if it's doing what it's supposed to, because brains, like muscles, are supposed to be active pretty much all the time. But you can tell here that there is less red over here, and that would be indicative that there's hypometabolism, meaning lower metabolism of glucose, and that's not a great thing. We don't want to see lower sugar intake. We want brains to be active. So that's something that we can use in order to tell us what's going on. I'm sorry that this is blurry, but I really like this graph because it's a great indicator, kind of similar to before, of the severity over time. So we have time here at the bottom, and as we go on, increasing time, and then severity means how bad is it versus how not bad is it. So it's a little bit reversed from the previous graph, but just minimum severity, normal functioning, that sort of thing, maximum severity is at the top. So as you can tell at the beginning, everything's pretty much below threshold of detection for our current modalities. And what we currently use, just like what I had mentioned, is our neuroimaging and our lab values. So that CSF, that fluid that can tell us about Alzheimer's markers, that's what we're using, and we're using neuroimaging. So someone comes to us and they're saying, oh, I have a problem. We kind of pick them up around here. So we test for amyloid ratios, right? We talked about amyloid plaques earlier. We test for amyloid ratios. We look at their amyloid PET. If insurance won't pay for the PET, we'll do the fluid. But typically we'll be looking for some sort of amyloid in the brain, and we're going to be able to detect that with our current evaluated measures. We get an MRI, we can get an FDG PET, and then sometimes, as we go on from the normal to the mild cognitive impairment to the dementia, we're able to see them increase as we go on. So sometimes these can qualitate how severe something is. But really, we know how severe it is based off of their functioning, right? I mean, if they're looking like they're worse, we don't really need it for that. We just need that initial, this is what's happening. So that's why we use this. And it's very helpful with everything we've done with research up until now. This is another along the same lines graph of, functioning in daily living over loss of function. When we do that cognitive testing, those 3 things that I had on the right there, the mini mental status, the MoCA, all of those cognitive testing that we'll do. They graphed the MMSE, which is one of those tests, against daily living. And they noticed that the worse your cognitive status was on that mental testing that we do in the office visit, it correlated with your ability to function in your world. So for example, someone with an MMSE that was a little bad, not super terrible, they were having trouble keeping appointments. They were having trouble using their telephone or getting their own meals, snacks, or traveling alone. And as it worsened, they noticed that it was difficult for them to make decisions on selecting their clothes or grooming themselves. And at the end, they noticed that they could barely walk or eat. So they noticed that as they progressed in the worsening of their cognitive testing in the clinic, we could kind of correlate that with their functional ability. And that's why cognitive testing is so important. It helps us gain a gauge into your world because we're not with you every day. So this is the best thing we have in order to kind of put us in your shoes, if you will. So what do we do about it? We found out that there's a dementia. We found out that there's something wrong. We think it's Alzheimer's. Well, what do we do for it? Well, we have 2 medicines, oral medicines, that have been on the market for several years. We have cholinesterase inhibitors. These are more for mild cognitive impairment. They're more for, we know that there's a problem. We're making sure that we understand more about what's going on. These help with symptoms of memory and thinking. They're the medicines like Aricept or Exelon or donepezil, rivastigmine is what you may know it as well. Those are usually our first go-to medicines. They help jumpstart our synapses. So if you think about it, it really helps our brain talk to each other in a better way than it would normally. So that's why we like using those medicines. It increases the acetylcholine in our brain, and that helps our synapses function better. So that is something that is usually our first go-to when we're giving a medicine to someone with memory problems. We also have our NMDA receptor antagonist, which is Namenda or memantine, and that is usually more used in moderate to severe dementia. That's more so going to help with your ability to perform simple tasks, helps more with your functioning. There are some times in certain cases that we will do memantine or Namenda first. For example, if you've tried donepezil and you're having a rough time with, GI upset, which isn't frequent, but it does happen, then we'll start you on Namenda first and then see how you do, and then maybe ease on to another medication later on. But those are the 2 medicines that we currently use for oral. This slide is really important, and I'm sorry that it's blurry, but this is basically a slide that says, even when you stopped donepezil, you still lost the treatment benefits as compared to if you had just continued them. So again, I'm going to tell you what the graph says. So this is time at the bottom, and then it says mean change from baseline. So basically that just means that the 0 is change from baseline. And if you go above, it's better. And if you go below, it's worse. That's what that means. So average is here. The yellow line is the donepezil. The yellow and red are both donepezil. They're just the 2 different doses. So that's the medicine we just talked about, the one that we normally go to first. We see that there was an improvement in functioning. And then when you stopped it, there was a decline. But then they noticed when you started it, they got better again. And it still slowed out that worsening. So that's why we always recommend the donepezil first. That's a really great first choice for us that we like. We also noticed that with a placebo, again, placebo effect got better once they started a medicine, but then they realized they weren't actually doing as well, and then they decreased ever so slightly as well. So it's not a huge dramatic effect, but we know that even the moment we start you on a donepezil, it might have the potential to help you long term. So that's why we usually turn to that one first. There is also a synergistic effect between the donepezil that I told you about and the Namenda that was on the right side of the screen. We know that together, they will help you better. So this bottom pinkish rose line is no medicine. And that's basically, this left side is basically functioning again and time. And they notice that there's a normal decline in function over time if you do nothing, right? That makes sense. Did nothing. If we just give you Aricept, or the acetylcholinase inhibitor, we notice that you're a little bit better over time. But then if you do both of the medicines we just told you about, you seem to do a little bit better than either one or neither of them. So we like to optimize our patients and give them both. If there's side effects, we'll take you off, we'll consider different things, but this graph shows us the whole intent behind our current treatment, where 2 is better than 1. A lot of questions that we get are, what are the new medicines for Alzheimer's? What does it look like? What blah, 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 blah. So I'm gonna tell you today. There are 2 FDA-approved IV medications that are monoclonal antibodies that function against amyloid plaques. They are Leqembi or lecanemab, and they're Kisunla, which is donanemab. Leqembi came out first. This was FDA approved in July of 2023. And Kisunla was just approved in July of 2024, so a few months ago. We've known about these medicines for a while. They've been in clinical trials for a long time. I think we were actually part of the Leqembi trials, right? So we've known about them for years, I mean, like 15 to 20 years, because that's about how long it can take to develop a drug like this. So we've had these in the pipeline for a while. So we're really excited that they're out. They're not without their side effects and evaluative needs for certain patient populations, but all the same, it's not a cure, but it's aiming to slow the progression of disease. The main difference between these 2 is the infusion rate, is what we would say. We still need some more evidence about how they're different, but they both function at about the same molecular structure for your purposes. If you guys were researchers, I would say a completely different thing, but ultimately they're both working on the amyloid plaques. This one is every 2 weeks. This one is every month. So for our participants or patients who are very far away, who it's very difficult to get those infusions, that might be a better medication. We do not currently have Kisunla on formulary. We are still only doing Leqembi here at Sanders Brown. There are other people who might be doing Kisunla. I don't know. I don't work for them.
So are those just for a study?
I'm sorry.
Are those just for a study then right now? Or
They are FDA approved, and we are actively treating patients with Alzheimer's with the Leqembi. Yes, I think we have 65 infusions going right now. Like we have 65 patients on it right now, and it seems to be going okay so far.
How does insurance usually cover that? They usually pretty good with it?
They've been good so far because of the FDA approval. We've gotten a lot of Medicare and Medicaid like approval for it because they're the ones who were primo drivers of it, which has been great. And so we're in the process of just making sure we have to submit to a website. They have to approve it. It's not been so bad. There's been a couple of pushbacks, but for the most part, we're doing good. So yeah, I know, I'm surprised too. Did I answer those questions? Oh, yeah. Like I mentioned earlier, this is not for everyone, this medicine. If you are so severe in your Alzheimer's, we're going to increase the risk then benefit ratio. Again, the main point I want you to take away from the Leqembi is that we're hoping to prevent progression of the Alzheimer's for up to 6 months. My grandfather died of Alzheimer's, and he was progressing at a point where I wish I had had 6 more months with him of quality time. And that's really what we're trying to have right now with these medicines. If I can tell you what my standpoint on it, and that's not me as a doctor, that's me as the granddaughter of someone who had Alzheimer's. And so that is why I advocate for this medicine, is because we don't have long-term data yet to say they're less likely to convert to Alzheimer's, in the future. We don't know if they'll need a second round. We don't know. Some of these medicines are, you take them for a certain amount of time and then you stop, is what their trial said. And then there's others that said, we just are going to keep going because we know that amyloid is going to reaccumulate. So we're not at that point with our research that we know one is better than the other. So all we can just do is try our best. So with that being our best, we have to make the best decision with the information that we have at that time. If you have bleeds in your brain, this is not a great medicine for you. It has potentials for side effects of ARIA, which I'll go into. So we want to be careful and we want to be good stewards of your health. It can be edema, which is swelling, or the hemorrhage, which is the bleeding. And ARIA itself is the amyloid-related imaging abnormalities. Because this is such a big deal for us, because it can happen, we know it can happen with these medicines, you need to be able to get MRIs pretty frequently. What does that mean for you? Well, if you have a pacemaker that isn't MRI compatible, you're not going to be able to get this medicine because we need to protect your brain. So that is important. And there's other things that are not MRI compatible, like sacral stimulators, things like that. So just being cognizant that this is not really for everyone. We gotta make sure that you're safe.
Is insurance a problem with frequent MRIs?
Yes. It can be. We are usually pretty decent about getting it here. We have a safety program already defaulted in our medical record system. That if you have not gotten your MRI, like if for some reason something happened or whatever, you cannot get more infusions until we address that. And that usually entails a call to insurance saying, hey, this person needs an MRI, blah, blah, blah. Usually the safety scans are not the problem. Usually it's the scans that we need when someone comes and is like, I have a headache. We're gonna get a stat MRI at that point just to make sure there's no ARIA. And sometimes they're like, well, you just had one a week ago. Why do you need another one? So we have to explain. Typically not a problem, but that is something that we do deal with. That's a good question.
One other question.
Yeah.
The second point on the last slide was the degree of advancement of the disease. What is the metric that we could understand that you use to determine that point?
So we will typically determine that for you when you come into our clinic and you score a certain number on our mental status exams. There is a limit to which we.
So there's a MOCA score that you can't go below.
Yeah, I think it's 16 that you cannot be below. Insurance will not approve it if you have a MOCA of 16 or less or an MMSE of 22 or less, if I'm not mistaken. And those are two really important numbers that we use. So. Another question I get a lot is ApoE status, the genetic testing that a lot of people talk about. Just because your family member had Alzheimer's does not mean that you will have Alzheimer's when we're in this testing area. There are people, let me start over, with genetics in general, brief genetics lesson. When we're born, we get 2 copies of our genes, one from our mom, one from our dad. When we talk about the ApoE allele, we know that that can be associated with the chance to have Alzheimer's. It increases our risk if we have an E4 allele, meaning you inherited an E4 allele from one of your parents. No getting to judge which parent had which, but we know that E4 will increase our risk for Alzheimer's, and we also know E4 will increase our risk for potential for bleeds when we're on the medicine. So it's really important before we start you on a medicine that we know your risk so that we can tell you this is the risk of the medicine. That also, correlates with if you're on a blood thinner, things like that. But for now, we'll just stick with this. If you have an E2 allele, there's actually some evidence that shows you might be protected. E3 is just the normal population risk for Alzheimer's. So what we're doing is we're looking for if you have an E4. If you have, E4, that's going to be a higher risk than if you had an E3, E4. Does that make sense? So us understanding your genetic risk and your genetic profile will help us describe the risks to you for this medicine. Obviously, we can't tell the future, but that's the case. Unless you have a known genetically inherited Alzheimer's disease, again, just because your mom or dad had it doesn't mean that you will necessarily get it. You can be E4 and never have Alzheimer's symptoms in your life. So that's why we don't do testing on this for asymptomatic patients, because it's not going to change your management at this point in time. It might change with research down the line, but for right now, if you don't have any symptoms, it's not going to change our management. And so we'll just reassess later on. We'll continue to watch you if you like. Your primary care can watch you as well. And at that point, then we can make that decision moving on. This is just some more information for you. When I said E4, that's what we call a homozygote. Homo means same, E4. And your lifetime Alzheimer risk can go up to 57%. So that's giving numbers to what I just said. If you're a E4 heterozygote, meaning you have one E4 allele, you have a maximum inheritable risk of 30% for having Alzheimer's. So those are all things. And then we talked about the increased risk of ARIA. And then I can let you read through the rest, but it's not as important as what I had mentioned to you. Oops. Okay, there are a lot of numbers on this slide, but I anticipated there were some potentially medical people in this room because we had some medical people at our last caregiver visit. And so these are the numbers. It's a lot of numbers and it can get overwhelming. So I'll tell you the risk of Leqembi ultimately in the way that the numbers were said. So ARIA H is the hemorrhage part, right? The bleeding part that we're looking at. We noticed that there was a 17% increase with lecanemab versus 9% on placebo. Placebo meaning participants with Alzheimer's who didn't get the drug, right? ARIA E, which is the swelling, was 12.6% with lecanemab versus the 1.7% with placebo. So obviously an increased risk, right? We're giving you a medicine that's doing something. We're going to anticipate there to be some risk. The good news to all of those numbers is that most of the problems were mild to moderate. And 91%, if they were to have one of these things happen, it was only mild to moderate. And most of them were actually asymptomatic. 78% were actually asymptomatic to the side effects that occurred. Now, most occurred during the first 3 months of treatment period. Think of it as your brain is in the process of getting out all that amyloid. It's like a vacuum. It goes into the blood to get rid of it, and then you pee it out. So ultimately, there's a lot going on in those first 3 months of getting rid of the amyloid in your brain. So obviously, the most side effects are probably going to happen in the first 3 months. We had about 71%. Most of the problems resolved within 4 months after they had been detected. So those are decent numbers, right? We had a problem, it was pretty much asymptomatic. We either held the medicine for a little bit of time or longer, depending on what happened. We waited for them to stabilize. We resumed the medicine, things seemed to go okay. Or we didn't resume the medicine, they were still okay. That's why we're doing all of those MRIs. The frequency of symptomatic ARIA-E, because I know that's what you guys are probably asking about. If you had 2 of the E4 alleles, the homozygote that we were talking about, the highest risk, there was a 9.2% chance of ARIA-E, so the swelling. If you had 2 ApoE alleles, you would get a 39% chance of ARIA-H, which is the bleeding. That's the one that we're really concerned about because that can cause swelling, that can cause a lot of really dangerous things. So when people start getting these medications, if they start having symptoms, then we typically end up being like, okay, let's get the MRI now. Let's make sure a CT is not going to cut it. Got to be an MRI. So now that we've talked about all the nitty gritty stuff, I'm going to talk to you a little bit about behavioral symptoms of dementia, especially as we go into the holidays. I really like this graph because at your diagnosis is this red line. We can see that there are behavioral changes, whether it's anxiety, depression, mood, what have you. We can see that that even starts 40 months before your actual diagnosis. So a lot of times we're just extra careful. We want to make sure that your mood is okay. We want to make sure that your anxiety, if there's any paranoia, that we're addressing that as we go. After your diagnosis, typically you can have what we call disinhibition. Maybe you're a little bit more inappropriate with your family members. Maybe you wander, maybe you get agitated. When people try to help, get agitated. And it's not your fault. Use the patient, it's not your fault. It's just the brain doing what it thinks it's supposed to be doing with this pathology going on. So these are all really important to acknowledge. And then frequency is on the y-axis. So having suicidal ideation is not as common as having agitation, which is about right. I'm sure that you've heard a lot of Alzheimer's patients who have agitation. Causes of behaviors, we need to identify that most of the time when there is a behavior that is unwanted by a family member, there's usually a reason behind it. And I've listed out all of the reasons here, but if someone can't see, they're going to act out, right? I would act out if I couldn't see what I was doing. If my eyes have cataracts or glaucoma, or I haven't had my eyes checked in a while, if I can't see what's going on, I'm going to freak out. So having, making sure that, lighting is okay, making sure their eyes are, your eyes are seeing, hearing aids, really important, especially for our vets who have been exposed to a lot of loud noises. Those are really important. Having any new surroundings, a lot of patients tell me, oh, I get really confused when I go somewhere else, like on vacation, or if I go to someone else's house. That can, again, their mapping capabilities are not quite what they used to be. They can't map their surroundings immediately for a couple days. So it's really important to understand that a good structure, not to say you can't take them on vacation. That's not what I'm saying at all, but just understanding that it might take a little bit of time for them to get used to their surroundings, and just having a calm environment is really important, and making sure that you match their level of calmness or matching their agitation with a level of calmness, which might be really difficult sometimes. And we understand that too. If they're bored, that's also a potential. like Sarah was mentioning, doing things is really, really important, having a structure to the day. Like at 8 o'clock, we wake up for breakfast. At 10 o'clock, we do a puzzle. At 11 o'clock, we eat lunch. At 3 o'clock, we go for a walk. And then at 5 o'clock, we eat dinner. And at 7 o'clock, we have, things like that are really helpful because change is a little bit difficult in some situations as we get more progressive in the Alzheimer's. So those are all really important things. Also, pain is another reason that behaviors can come about. I typically will recommend, a Tylenol just to see if they're at the point where they can't tell you how they're feeling, then that's something that I would typically recommend. Sometimes also my patients can have urinary tract infections that almost seem like a light switch when they are paranoid and have delusions. And so that's something that we look for as well when we're having people. In regards to intervention, I always go first with redirection, making sure they're in a safe environment, making sure they're pain-free. We talked about routines, making sure that we're supporting the caregivers, because that's a really important aspect of their care. We need to support both in collaboration, and then ensuring that they're adequately hydrated, having good food. And then we always want to treat the dementia first. When patients come in, we typically will put them on one of those memory medicines first before we even do a mood medicine, because if you treat the memory, that typically will follow suit with their behavior. They'll improve in their behavior. Now, that's not always the case, but that's typically what we go to first. I need to tell you about medications for severe behaviors. If you're in danger, if there is a concern that they are kicking, hitting, screaming, if there are guns in the house and you're concerned that they are going to, take the gun and come upstairs and harass you, those are the points when we turn to not redirection, those require medications. And the reason we don't do those medications first is because it comes with a black box warning. A black box warning is something issued where there might be increased harm to the person receiving it. And in our elderly population, specifically those with dementia, there is a warning of increased morbidity and mortality in these medications. And I don't know, there's an increased risk difference in mortality by 1% with an odds ratio of 1.54%. It's basically telling you that there might be a smaller chance that they might die from being on this medicine. It's very small, but it is present and it's something we watch for, and it's not something that we take lightly. Okay. So when you come in, we're going to consistently say we would like to redirect. Let's make sure they're structured. Let's do non-medication things first and then go from there. Otherwise, we like keeping a behavioral journal because sometimes you can pick up at certain times of day when the behaviors are worse, and that can help you with the reorientation on the flip side. And these are just a couple common misconceptions. I am over on time, so I will leave these here, but these are all misconceptions, and hopefully throughout today's talk and this afternoon's workshop, you'll see why these are not right. And I think that's everything. Make sure I don't have anything else. Yep. That's it. Any questions? I know that was a lot of information. Yes.
How common and at what stage are these antipsychotics normally prescribed?
It's usually in the severe dementia unless there was like a predisposing condition beforehand. So for example, there's a lot of patients that I have with maybe alcohol abuse, and they're a little bit more disinhibited in their older ages. And so the dementia kind of compounds that. And so those are patients that I typically will do an antipsychotic. Quetiapine is usually the one I go for. I'll typically do that a little bit earlier on, just if there is a risk for safety. And always be okay to call 911 if you feel like you are unsafe. Excellent question. You know, a lot of good questions.
I've done this too long.
Yeah. Well, ask away. I'm here for y'all.
Are there any behavior journals that you would recommend?
You know what? Now that you mention it, I don't have a specific journal in mind. Usually, because sometimes behaviors don't happen every day. Usually I'll have someone take their cell phone, and in the calendar, I'll have them put agitated or whatever. And the cool thing about the phone is that when you come to the office, I'll say, how often were they agitated? And you can actually type search in your calendar. You type in, you search agitated, and it will come up with all the days that they were agitated. And so we can have more of a qualitative measure of what is going on.
Okay.
Yeah.
I've also had caregivers just use their note feature and their
Yeah.
phone, they just kind of do the date and then what's going on so that when they're here, they just pull up their phone in their notes and they say, oh, this day this happened, this day this happened.
Yeah.
And so just kind of keeping it there, or just paper, too works.
As long as you remember to bring the paper.
Right.
People always have their cell phones with them, so I think that's a really good thing. Anything else? Thank you so much for being here today. We appreciate you guys immensely for taking charge of your care and your patient's care or your significant other's care. We know it's a lot, but hopefully we're here to help you as much as we can. Sarah and Kelly are amazing, and we have wonderful people all over giving us resources all across the country. So we have a lot of support and very thankful for that.
Thank you.
Thank you very much. All right, I'm off to clinic.
Thank you.
Thank you.
Alright. Switch gears a little bit, and we're gonna go talk about resources quickly.
Thank you all so much for being here. I'm Regina Goodman with the Area Agency on Aging and Independent Living, and that is a mouthful to say. We were aware of that, and so that's what this presentation is just a little bit about, just telling you more about what we can do in the community. And so if you've talked to me or anybody in my office at all, you know that we love our acronyms, and so this is just a list of some of the acronyms that we use. So we are the Bluegrass Area Agency on Aging, but the state level is we call it DALE, the Kentucky Department of Aging and Independent Living. We are housed at the Bluegrass Area Development District, which is located at 699 Perimeter Drive. But within that building, we have several other departments, and our department is the aging department. We also have a workforce, community planning, and things like that. But I represent the aging programs. And so every community is served by an area agency on aging, and our area covers Fayette and then 16 surrounding counties, so total of 17 counties. In the middle of the table is our Pathways Guide. And if there's anyone on Zoom that would like a copy of that, if you can put it in the chat, and maybe if Meredith could relay that information to me, I will mail that to you. But what's good about that guide is it gives you all the resources in one book. I kind of call it like an old phone book, and a lot of people don't know what that is anymore. But I know that you can find this stuff online, but with this book, it's all consolidated, and you can look it up by county, you can look it up by subject. There's information on housing, on nursing homes, on just housing options for the elderly. It's got advanced care planning, just lots of information within that one book, and we produce that book every year. It varies. It used to come out in the spring, and now maybe it's the fall. I don't know, but this orange version is our newest version, and so we welcome any of you to take that. And then if anyone, like I said, would like that, I can mail that to you. And then our mission is to promote and provide for the development of community-based systems of care, which include planning, access, and delivery of services, coordination of activities and programs, and advocacy. We do not provide direct care services in our building, but we administer the programs that provide those. And I'll talk a little bit more about those in detail. So we had 17 counties. So here's the 17 counties that we serve. If you live outside or have a family member outside of these counties, we can help you find the correct one that would meet your needs. There are 15 across the state. And so these are just some of our programs that we have. The Aging and Disability Resource Center, our funding goes to fund the senior centers, the nutrition programs, home delivered meals, home care, the nursing home ombudsman, agency legal services, SHIP, health promotion and disease prevention programs, the National Family Caregiver Support Program, Medicaid waiver, the Kentucky Caregiver Program, Bluegrass Mental Health and Aging Coalition, and Elder Abuse Prevention. So those are just some of the programs. And then one of the newer programs, I think that they're, I saw when it was flashing on the screen, one of the newest programs that we offer. A few years ago, I think maybe going on 3 years now, the state realized that there needs to be another layer of support for people with dementia. And so they instituted the Office of Dementia Services. We have not added that to our list, but we probably need to. So through that, the state had a grant called Bridging the Gap. And so that is another program that we have that's kind of an extension of our National Family Caregiver Support Program, which when we get to that, I will go into more detail about that because that's my favorite thing to talk about. And so this is the Elder Nutrition Program. The congregate meals are served at the senior centers. And the eligibility, you have to be 60 years of age or older, have a spouse or an individual of 60 years of age or older, have a disability, or live at home with an eligible older individual. So typically with the home delivered meals, it's for people who cannot get out to the senior centers. They really want to encourage those congregate meals where you can go and have a meal. They usually have activities planned, and it's really for socialization. And here's some more about the nutrition program. Like I said, that's going to be in that guide as well. Most of our funding is through the Older Americans Act. Tells a little bit about there, and I think they're going to be sending this. They're going to be sending this out. So I'm gonna spend, since I don't have a whole lot of time, I'm going to spend most of it talking about the programs more closely related to caregiving. And so this is our National Family Caregiver Support Program. It is funded through the Older Americans Act. Through this program, where a lot of programs are direct care for your loved one, this program is to support the caregiver. So we offer $2,100 of respite care per year. Now that is a fiscal year, which goes from July 1st through June 30th. So we're almost, believe it or not, in the middle of our fiscal year. It started over July 1st. It is funded through the Older Americans Act, so there are no income guidelines. You just have to be caring for someone 60 years of age or older that has some deficits in their activities of daily living and instrumental activities of daily living. Which is on this screen. The caregiver can be any age, but the person you're caring for has to be at least 60 or younger with a dementia diagnosis. Under this umbrella, we also help grandparents or relatives who are raising their grandchildren. And for this program, it's not income-based, but the grandparent will have to be at least 55 years of age or older. And I just had a day yesterday at Walmart. With that, we help them purchase clothing, personal hygiene, school supplies, things of that nature. We actually have two ways to help grandparents. And the other one is the Kentucky Caregiver Program. This one is state funded, where the other one, the National Family, is federally funded. It's still helping with those items for the grandchildren. Except for this one, it is income-based. So you do have to submit an application, and then you have to submit any income documentation and things like that. And you have to show that relationship that you are that grandparent. But with this one, it is income-based, so you get a little bit more assistance. So it's per grandchild, where the federally funded program is per grandparent, and that's $500. So $500 per grandparent. And in the state program, $500 per grandchild. The Medicaid waiver services, participant directed services, you may have heard of that. That also goes through our office, and so it's an alternative to institutionalized care. This is not an easy process. It's not a quick process for any of you who have been through that. But this could offer the direct care services, where I said the caregiver programs for the caregiver. This would offer those in-home services to keep your loved one at home for as long as it is safe to do so. And this is more about the Medicaid waiver services, which will also be found in that book. The state health insurance assistance program, which I think we're still in open enrollment for that, so they can help with those Medicare decisions. And then also legal services, free civil legal advice, no assistance in criminal law. And then this is how to report elder abuse. And then these are some of the programs that are also funded through the Older Americans Act that are usually can be found at the senior centers. They offer these at the senior centers. This is our home care program, which is also a type of in-home direct care assistance with homemaking and personal care and things of that nature. And it lists all of those there that the home care can provide. Okay, sorry. So I thought that we had a slide about our Aging and Disability Resource Center. If there are any of those programs that you saw on there that you would like to sign up for, you have to call our Aging and Disability Resource Center, which is the 866-665-7921. So say you've heard about the National Family Caregiver Support Program. I can tell you about it. You can call me and I can tell you about the ins and outs of it, but in order to actually sign up for that program, you have to call that number, the Aging and Disability Resource Center. We are on page 10 of the Pathways Guide. So what will happen, you will call, you will leave a message, you will more than likely not get to speak to someone directly. You'll leave a message. They answer those calls in the order that they are received, so it's not necessary to keep calling back. Someone will call you back, and then they will provide that screening. They'll just ask you the questions just to make sure you're eligible for those programs. And then they will send, if it's the caregiver program, they'll send that information to me. We will send that application out. You will complete that and then return that. And this year, we have received more applications, I think, than in the last 8 years that I've done it. But if you do call that, just be patient. They will call you back, and please make sure that you're that they're able to leave a message on your phone, because a lot of times the mailbox will be full. You know, you will have waited a couple of weeks to get that phone call, and then maybe they miss you because the voicemail isn't set up. If you do miss the call, they will leave a message, a detailed message, and so just make sure that that is there. I know that I've given tons of information. Does anybody have any specific questions? Yes.
I had a call last week from a lady named Robin Stewart. Is she one of your?
She is. She's with our ADRC, and so if you have called that number, maybe you've called about Medicaid waiver, they will help you through that process. If you've called about the caregiver program, so yes, call her back and she
No,
will.
I talked to her, but she was pretty much we talked through the 5 o'clock hour and she was pretty well spent, but I'm expecting some stuff in email.
Perfect. So I may have gotten, if she referred you to my program, then I will have gotten your name. I actually have 1.5 assistants that help me with all of this paperwork. And so someone will send you that application out pretty soon, and then we will get that back. And just because of the amount that we have, it may take a little bit, but you will, be approved eventually for that rest. But I want to talk, am I out of time? Just real quick. So we talked about, when Sarah was talking about some of the assistive technology pieces, when I talked about the Bridging the Gap program, we can also provide that's like an extension of the caregiver program. That is that grant through the Office of Dementia Services that I mentioned. And so if you all are interested in that and you call the ADRC and I'll talk to you, just let me know that and we can get you through that program so that you can get some extended respite and some help with that assistive technology. So I know I gave a lot of information. That is my direct phone number. If you want to just call me and say, can you go over that again, I'll be happy to talk to you, one-on-one about our services and specifically our caregiver programs. Thank you.
Thank
Thank you very much.
All right, so we got one more to go.
40 minutes, I guess. So hi, everyone. My name is Jenny Furman, and I'm a volunteer with the Alzheimer's Association. I'm a community educator, which means that I go out and I give presentations like these on a number of topics. Today, it's going to be focused on caregiver support, but we also have programs just talking about healthy aging, communication practices, behaviors related to dementia. So these are all things that if you're interested in, we probably have programs for them, and I'll go through some resources to how you can find those in a little bit. But this is just one module of an empowered caregiving workshop. And so really what we're going to go through is information about effective caregiving and skills and tips. And so I'm curious, is everyone here a caregiver or yeah, okay. So hopefully this will all be informative to you. Feel free to raise your hand, ask questions throughout, and we will get through these slides. So in this conversation, what I'm hoping is that we'll go through the role of the caregiver, which should be pretty quick. You guys all are caregivers. Explain relationship changes that might happen over time while you are caregiving. Describe 5 areas of person-centered care, and I'll go through that in more detail. Identify possible members of a caregiving support team. And then lastly, list action steps that can help lower caregiver stress, which is something that I'm sure you're all familiar with and that might increase around the holidays. Okay, so who is considered a caregiver? That can be a family member, it can be a friend, it can be anyone really who's giving their time to help care for someone with Alzheimer's disease and dementia. And so most people do not have formal training with this. So it can be difficult if you don't and you're just thrown into it and you kind of learn along the way. But know that you're not alone and that most people are in that same boat when they start out. So you may not feel prepared, and hopefully this information is going to give you again, a little bit better of an idea, some things to think through for effective caregiving. So there are a few ways that you can control your role and live well as a caregiver. And so with the right help and support, what we hope is that you can be a great caregiver for the individual that you're caring for, but that you're also able to take care of yourself through the process, because that's really going to lead to a better experience, not just for the person you're caring for, but also for you and maintaining your health. So I'm going to do a quick knowledge check here, and that is someone who helps a person living with dementia with everyday tasks like grocery shopping or managing doctor's appointments could be considered a caregiver. Would you agree with that or disagree? Agree, yeah, exactly. And so really what we want to highlight here is that no matter how small the task or how large, if you're helping that individual, you are a caregiver. You're an important part of that team and you play a very important role with their health and well-being. And so some of these tasks, you know, they can range from just household chores to some of the more important things like managing finances. So caregivers, again, they can really do anything across the spectrum. So whether that's stuff around the house, like laundry, cooking, setting the table, or they can also be responsible for some of the larger tasks, like scheduling medical appointments, picking up prescriptions, getting someone to their medical appointments via transportation. So it's really all activities associated with daily living. That's where caregivers can assist. And so you as caregivers are part of a very large population in the United States. So more than 11 million people provide unpaid caregiver support. So there are over 6 million individuals who have Alzheimer's disease or dementia, but 11 million people who are helping care for those folks. So
again, it is a very important role and it's one that a lot of people are having to step into, especially as the population continues to age. This can be family members, friends, or other unpaid caregivers. So it's really not limited to any specific relationship. And then they can have caregiver roles. And then one thing to note is that you don't have to be in person to be a caregiver. So you can be providing support even if you're not with that individual. And likewise, you can reach out for support from others, even if they're not right there and able to be physically with the individual with Alzheimer's disease or dementia. And so you can see that about 2/3 of people who are caregivers say that it is a stressful job. And I won't ask for a tally, but I'm guessing that would be the same here in the room. But also 92% say it's rewarding. So they recognize the importance of it and they understand, that they are letting this individual continue to live their best life. So I want to go through some changes that caregivers may experience. So every person with Alzheimer's disease or another dementia, they're going to be different. No two people are alike, and so no two experiences are going to be alike. But what we're going to do is go through kind of 3 of the most common challenges that you can expect to face as a caregiver. So if you haven't already, then it's something that you might experience. And that's not to say that it absolutely will, but again, these are just 3 of the most common. And so those are taking on new roles, relationship changes, and intimacy. So we're going to go through each of these in a bit more detail. So taking on new roles. As the individual progresses with their disease, it's likely that your responsibilities are going to change as well. So what might start out as you needing to simply help put dishes away, it might turn into you having to cover the spectrum of household chores, help them bathe, help them get dressed. So things that seem, kind of mind-boggling like that, it'll eventually reach that change. Know that it might over time. And it can be, I kind of alluded to this, it's redundant, but it can also be more than just household chores. So it can be making sure someone's paying the bills, managing finances, managing legal matters. All of these are roles and responsibilities that someone will have to assist an individual with. And so what can you do? How can you help plan for these challenges? What you want to do is have conversations about the future and put plans in place as soon as possible after there's been a diagnosis. And so I don't know how far along everyone here is with their caregiving. If it is in the earlier stages though, what we recommend is you have these conversations with the person that you're caring for while they can still communicate. They can still tell you what they want and how they can help. And so that's going to do 2 things. It's going to, 1, make that person feel more empowered and that they're being heard. But then also it's going to help you to understand what they want, to make sure that you can give them the best care. So again, it's possible that some of you are already caring for someone who might be beyond this phase. But if it is soon after a diagnosis, then just keep those in mind that the earlier you can have these conversations and prepare for these roles and responsibilities, the better. The next is going to be relationship changes. And so a lot of times what happens is social isolation becomes common. And so that is twofold. It might be that you are exhausted and overwhelmed and thus kind of, retract from what you would normally want to do in your social life and seeing other people. So perhaps you don't talk to your sister every week like you used to do, or go out and get dinner with your friend. So that's something that you might step away from just because of your new roles. But also it's possible that those individuals don't reach out to you as much either because, perhaps they just feel that a little awkward interacting. They don't know how they can help either you or the person with dementia. And so what it leads to is just this separation where you can feel isolated. And so what we want to do, or what we suggest you do, is just reach out and maintain those connections. Let people know that you value their friendship and support, and then consider inviting people over and kind of priming them for what to expect. So I want to give an example just because I know the holidays are coming up, and a lot of time that is when people get together, they enjoy being around one another, they have conversations. It's really a time where you may not see a lot of people all at once, and then it's this time where they are coming. So, I'm going to use the example of just if you are caring for your mother, and let's say that your siblings are not around that often, but they will be for the holidays. If you're still able to have a conversation with your mother, tell your siblings that. Say, hey, mom, she's still really engaged in conversation. She can express her feelings. She's going to recognize you, but she really takes some time to process what you're saying. So you're going to need to speak slower, keep sentences simple, but know that she's still going to be able to communicate. So that way they know what to expect. If it's later in the stage of dementia and communication is a bit more of a barrier, also prepare them for that. Say, mom can still understand some things that you're saying. It's possible she'll recognize you. It's possible she won't. She can answer yes or no questions. So you can still communicate, but know that it can't really be complex discussions. And so by doing this, you're making individuals feel a little bit more comfortable with coming over, but also laying the groundwork so they can know what to expect. Also, just informing them ahead of time of dementia, just tips for communication, that can be super beneficial as well. So educate others and help them prepare, and that's going to make for a better experience with everybody. And then the last one is intimacy. And so this is not just physical intimacy, that's part of it, but also emotional intimacy. So the closeness between two people that might grow apart as the disease progresses. For a couple, for example, there is maybe going to be that lack of physical intimacy because a person with dementia or Alzheimer's disease, they might lose their sexual drive. They may have personality changes or depression that makes them not interested. Know that that's not your fault, and that is their disease. On the flip side, it might be that that person you're caring for is having personality changes and they just don't seem to be the person they once were. And so you may not have those desires. And that is totally okay. And that is not abnormal at all. So just recognize that that is a change that might happen. And, if it does, what you can do is kind of pivot and find new ways to be intimate. So you're still loving this person, you're still connected to them, and you just want to find different ways to maintain that connection. So, for a non-sexual connection, just think about holding hands or hugging. For an emotional connection, think about doing an activity that you both enjoy, like listening to music or going for a walk. You can also talk about favorite memories that you have together. So these are all ways where even if your intimacy has declined, you can still really maintain a connection with that person. And so here we're going to listen to, hopefully, a video from someone who is caring for her father, and she has some tips for how they stay connected.
When I think about caregiving for my dad, who's been living with Alzheimer's disease for 13 years, my expectation is not that my dad is going to remember my birthday or know how old I am, but I'm pretty confident that if I show up at his place in his memory care assisted living with some cake, light a candle and tell him, Dad, today is my birthday, he's gonna smile, give me a hug, and want to enjoy some cake with me. And so that gives me a glimpse into that love and that connection that's still there between us as father and daughter. I've had to realign my expectations, but that has allowed me to be more present and available for these happy and connected moments between us.
Okay, and so now I want to shift gears a little bit and really talk about best practices and recommendations for caregiving. And so what the Alzheimer's Association recommends is a person-centered approach to care, which I'm going to go into much more detail. But in short, what that means is that you as a caregiver are focusing on the individual and their specific needs. It involves using what you know about their likes, dislikes, and abilities to give the best possible care. And so this has benefits both for you as a caregiver and also the person for dementia. When it comes to the person you're caring for, it can actually reduce their dementia-related behaviors and lower the need for medication to treat these symptoms like irritability. There's less boredom and feelings of helplessness. And there's also an increase in happiness and a sense of well-being when you're taking this person-centered person-centered approach. Also, for you as a caregiver, there are a lot of benefits. So you're going to get confidence in how to address dementia-related communication and behavior changes. So you're going to feel more empowered to care for this individual and have those meaningful connections. You're going to show an increased satisfaction then. You may have a little bit less doubt than you might with yourself otherwise. And then importantly, you're going to have a better quality of life, both for you and the person that you're caring for. And so we have several strategies for person-centered approach to care that are listed here, and we'll go into more detail of, but those are using knowledge of the person, connecting in the moment, helping the person take part in meaningful activities, focusing on the relationship with the person, and creating supportive environment. So use your knowledge of the person. Likely as a caregiver, you are someone who knows that person very, very well, perhaps better than anyone else. And so you want to take their individuality and characteristics into account when you think about how to provide care. Ways that you can do this are to consider what makes them unique. So think through their values, their likes, their dislikes, and also keep in mind their abilities. If you are not someone who is super familiar with these things, then think about who to reach out to who maybe could help you understand those a little bit better. But really what you want to do is focus on that individual and what makes them unique. Keep in mind also that their hobbies and interests may change over time. So if what you're thinking about right now, you have a list of their likes and dislikes, kind of check back on that list every few weeks or every few months to make sure that it's still aligned with what you're seeing in their daily lives. Next is connecting in the moment. And so you can find out what they need, and that will give them the right support. So what we mean by that is try to see the world through their eyes. You just heard from a clinician, and I imagine she told you, but the changes that are happening in the brain with Alzheimer's disease or other dementias, they can make it so that person does not see the world as you do. So it's not that they are necessarily wrong. They are just literally experiencing it differently than you are. And that's going to change as the disease progresses. It could very well get worse. And so what's important is that you focus on feelings and not facts. And so also I imagine you heard, but what you don't want to do is correct someone if they say, if you're having a conversation, if they think one thing, don't turn it into something where you want to try and correct them. Instead, just understand again that they're probably experiencing things differently. And so you kind of need to adapt how you respond and keep that in mind. If a topic bothers or upsets them, switch to another one because it's likely that can just escalate and sort of small arguments can turn into something. Help make activities meaningful. So every experience and interaction is a chance for you to connect to a person with dementia, no matter how small. And so some of the ways that you can do this are to make sure the activity has meaning and purpose for the person. How do you do this? Like I've been saying, take into account their likes, dislikes, what you know is a passion of theirs. Give them choices. That's gonna let them feel empowered. So you're not just saying, we're going to do this, but saying, hey, how does X or Y sound? Would you like to do one of those? Know that the person can feel joy, comfort, and meaning, even when the dementia's advanced. So, you're making all these plans, you're doing everything you can to provide the best care possible. And you may not get verbal recognition of that from the person you're caring for, but know that they can feel it, even if they're not able to communicate that. Go with the flow. So it is nice to, again, take this person-centered approach and have a few strategies in mind for how to entertain them, connect with them, but know that every day is going to be different. And so keep that in mind. If you need to pivot, then keep that as an option. And this kind of ties in with that. And let's focus on a supportive relationship. And the way you do that is by putting that person before the task. So what that means is you want to take their needs and desires at any given point in time and prioritize those over what you initially may have had planned. So think through strategies that's going to make them happy in the moment. And keep this in mind for all of your caregiving responsibilities. And so ways that you can do this are to think about choice and flexibility instead of how much you can do in a day. And so to simplify that, it's kind of think about it in terms of quality over quantity. You don't need to have 17 activities scheduled, knowing that, the person you're caring for might love all of them. Maybe you spend 2 hours looking through photos and that's really meaningful to them. Pay attention to what's happening with the person in a certain moment. So it's possible that they may just be exhausted, not engaged, and that's okay. So if they need to, let them rest. And then when they're back and ready to connect, then start planning your tasks that you've already thought through. And then encourage independence. So do activities with them rather than for them. And an example I like to give here is doing laundry. So especially in a later stage, it's possible that that person is not going to be able to do their laundry. So let's say that there are towels in the dryer that are ready to be folded. Instead of just folding them yourself and putting them away, see if you can make it an activity that you do together. So you might suggest, hi mom, I'm going to separate these towels into washcloths and bath towels, and we can fold them together. And so that way she's still able to participate. You're doing an activity together. Is it going to be a perfectly symmetrical fold or roll, or however you guys like putting your towels away? Quite possibly not. But that's really not what's important. It's the fact that you're doing an activity together and you're still giving them some independence and they feel empowered that they're able to help you complete this task. And so this is an Alzheimer's expert who's going to talk through ways that you can kind of celebrate the small wins.
Caregiving can be difficult, but each day presents us with opportunities and challenges. So it's really important to celebrate those small wins, like providing just the right amount of support to have somebody successfully get dressed by themselves or brush their teeth or even set the table for dinner. Everything that happens throughout the day can be considered an activity. Little things like setting the table or going for a walk and talking about family, or even spontaneously dancing to some music are all things that happen throughout the day and time well spent.
And then the last strategy with person-centered care is creating a supportive environment. And so that means that you're going to help the person living with dementia be successful and independent for as long as possible. And I think that actually kind of captures a lot of the other previous strategies. So from the beginning, you want to talk to them and see what they think support means from you. You want to think about what they like and dislike so that you can create an environment that they're comfortable and happy being in. Some tips that we have are suggesting activities that they like, so they might get excited about, but even smaller is kind of think about the placement of things throughout the house. If you know there are certain hobbies that they like, put it where that's visible. So it might not be, if you were to ask an open-ended question, what do you want to do? There might not be anything that comes to mind. But if you have scattered throughout the house activities that you know they'll enjoy, just seeing that might be helpful and spur their memory and give them an idea of an activity that you could do. And then lastly, I think we're going to transition into spending most of the rest of the time with this, but take care of yourself. Ask family and friends for help if you are stressed or if you need a break. And the reason we say that is that you cannot be the best caregiver possible for someone else if you're not supporting yourself and you're not keeping yourself healthy. And so one of the ways that you can try and remedy this or get ahead of it, doesn't even have to be a remedy, but is to build a support team. And so I want to go through kind of the importance of that, who that could include, and then tips for developing a team. And so the first is simply the importance of a team. So it is going to make your life easier, is what it comes down to. You can get more done each day, and you're probably going to be less stressed in doing all of those activities in your day. You can not just care for this individual, but you can stay active in your own life and do the things that you need to do and the activities that you enjoy. It can also help lower your stress. So your team can step in when they're needed. It doesn't need to be a round the clock thing, but when you need them, they're available to help. And so who would you include on this support team? Oftentimes it's going to be friends and family. What's most important, unsurprisingly, is that it needs to be people that you trust and rely on. You want to make sure that they're aware of the disease and kind of some of the features that come with it. So no one who's critical or judgmental. Keep in mind that the care team, it might change over time as the disease progresses. And that goes back to how roles and responsibilities are going to change over time. So again, if you're caring for someone who's in the early stages of dementia right now, your support team is probably going to look a little bit different than someone who's caring for someone who is in the late stages of dementia. And so possible team members, again, it's going to be family members, friends, and then depending on the types of activities you need help with, potentially neighbors or others in the community. One other thing I want to point out, and I'll talk about this a little bit more later, but it doesn't have to be someone who's in person and helping you on a daily basis. So online communities like All's Connected is another way that you can actually get support, even though it's not directly impacting your day-to-day interactions. And I will come back to that. That's just a little kind of teaser. But so tips for developing your support team. Think about the type of help that you need. So think about what you're doing right now as a caregiver, and then ways that others could make your life easier, make you a better caregiver, kind of bolster those activities that you need. Talk with the people that you'd like to have on your care team. So this might come out of the blue, but you could just say, look, sister, I know that you're really busy with your schedule, but for the most part, I'm taking care of mom and I could really use your help. If it's a neighbor, hey, you're nearby, would you mind going and checking on my mom every so often? So again, it's going to really depend on the state, the disease progression, and then also how much you are caring for them. Don't take it personally if someone is not able to help you. You might ask someone and they're just not available. They're either not comfortable with it or they have too many responsibilities, and so they can't really prioritize their time. But for those who do support you, make sure that you show your appreciation and that they know that they're valued. And then they're more likely to continue assisting you in the future. And so one thing I want to just pause, this is kind of, this isn't something I could verbalize, but just, as a summary of the last few slides is to think about if you were to build a support team right now, which we recommend doing, not right now, but soon. You want to have this in place. So think about 2 people, if you had to right now, that you would reach out to that you think could help support you with your caregiving. And that can be, again, for a range of roles. So that could be transportation to medical appointments. It could be an emotional support person where you're feeling overwhelmed, or it could be someone who helps with household chores. But just think about a couple people who you may want to reach out to for your support team. And then also think about the kinds of help that you would need from them. So again, that's going to be very person dependent, but what do you think could help you the most? One example that I like to give is think about something that offhand seems pretty easy, and that would be, let's say, picking up a prescription. If you're caring for someone full-time, for example, and you need to pick up a prescription, it's going to take a long time to get them ready, to get into a car, to drive 15, 30, who knows how many minutes to a pharmacy, to pick up your prescription, to drive back. So again, this is kind of arbitrary times. That could take you an hour and a half to get the prescription. Maybe you have a neighbor who works right next to that pharmacy. You could simply ask them, hey, can you pick this up for me? And that's going to save a lot of time and a lot of stress. You just got an hour and a half of your day back, and you didn't have to go through what can potentially be difficulties with getting that person dressed in a car and transported. So again, this support team is going to be very personalized, but it's just something to think about. And I know that we're trying to tie this into the holidays. So I especially want to emphasize that it's probably worth thinking this through, because for me, even though I'm not a caregiver, the holidays are a very stressful time and you're juggling a lot of things that you're not normally doing. So it's quite possible that you're going to need more support. And if you can get it, why not have that in place? Next is caring for yourself. So I have said this before, and it's worth mentioning again, that unless you're taking care of yourself, you're not going to be able to optimally take care of someone else. That's just both in the short term, but then also in the long term. So knowledge check. Dementia caregivers are less likely to experience anxiety and depression than other caregivers. True or false? Exactly. So, and yeah, it's the opposite. So caregivers of people living with dementia are actually more likely to experience anxiety and depression than non-dementia caregivers, and they're also more likely to experience financial hardships and physical problems. So how do you take care of yourself? First is you need to know the warning signs of caregiver stress. You can see that there are a lot. If you read through them, you probably have experienced some, hopefully not all, but these probably are not unfamiliar to you. I do want to flag just a few of them that might be especially important to keep in mind with the holidays coming up. So social withdrawal. Again, I mentioned, and I'm speaking, how I feel. This might be different for others, but I really look forward to the holidays and being around friends and family and sharing that time that I don't necessarily get throughout the year. If you feel like you don't have a desire to do that when you normally do, think about it. That's probably stress coming from just exhaustion and fatigue of caring for someone else. Irritability. This is something that's going to have an impact on so many things around the holidays. So it could make things more hectic with your spouse at home. It could make things harder, with your job if you're trying to wrap things up before the end of the year. Or with that person that you are caring for, it could make things more argumentative between the two of you. So be on the lookout for this, because that has a way, it could really balloon into something bigger. And then lastly, health problems. And this slide goes a little bit more into what those problems can be. So if you are noticing things such as blurred vision, stomach irritation, high blood pressure, changes in appetite or sleeplessness, these are all things to be on the lookout for and to definitely talk to a doctor about if you notice them. Try to find ways that you can de-stress, if you will. And so these are just a couple examples, which is finding relaxation techniques. This could include breathing exercises, meditation. I personally think physical exercise is a great one. Our website has a whole list of possibilities for you to consider. Sorry, I'm speeding up at this point because I know we're getting close to time. But other things to keep in mind is to be realistic. And so grieve the losses and know that not every day is going to be easy. Even if you think through this person-centered care approach and you really think that you have ducks in line, every day is different. And so there are going to be times where things just don't go as expected. And so, you know, recognize that, but then shrug it off and know that tomorrow is a new day. And really keep note of all the fun things and happy times that you are able to share. Know that you're doing your best, and so don't get down if there is a bad day. You are doing everything you can for that person, and you're making their lives better. Take a break. So this goes back to using that support team that you're hopefully going to think through, but then also Regina gave some great resources, and that's where you can get respite care. So you can have other individuals, even if they're not your direct support team, but help out with some of these tasks. And then there are lots of community resources and care options available. I'm going to skip this again just because of time, but in your folder, right here, okay, there is a handout, a take-home activity that take the time to do. It's going to allow you to reflect on what I've gone through today, but really what it does is it goes through tips for reducing stress, but then also lets you reflect on your current situation and make a plan going forward. So you're going to think through what symptoms you might have right now that's causing stress, what triggers that stress, and then some tips for how you're going to react to that next time it happens. So again, this is in your folder. The benefits of being a caregiver, this was introduced at the beginning. It's tough, but it's rewarding. I do want to play this video. I think she captures it very, very clearly.
And my mom loves to hug. You know, we're huggers. And so my mom is very much, you know, and even now she will, you know, they're getting into bed at night. You gonna give me a kiss tonight? Can I get a kiss? And she'll kiss me. But often what keeps me pumped and what keeps me going as well, my mom tells me, I don't care what type of day or what she's done, she often says to me, I love you so much. Thank you for taking care of me. You know, and that means, especially there are sometimes when it's been a hard, long day. And at the end of that day, you know, she'll look up and she'll say, thank you so much. I appreciate you for taking care of me. And that makes it all worth it. It's like everything else, nothing else matters. It's like, hey, you know what? And that's the best feeling in the world, because when you're caring for somebody who can't necessarily tell you what's going on, to have them to say, I love you, I appreciate you, it makes it all worth it, because it lets you know that you're doing something right.
Okay, and then this is the very last slide, I promise, but I want to go through some additional resources that might help you with caregiving, you know, be it now, be it in the future, around the holidays. The Alzheimer's Association has a number of options. So we have a 24/7 helpline. This is free of charge, available to anyone. When you call, you're going to be able to speak to a master's level clinician or above. So they're going to be very familiar with the situation. They're going to be able to help you with a host of things. So whether you have a question about caregiver support or the disease itself, they're going to be able to answer it. They're also available in times of crisis. So with the holidays coming up, if you just feel absolutely overwhelmed one day and need to speak to someone and have questions, call this number and you're gonna be able to talk to someone. There are local resources, so Meredith, have you gone through these?
We have a lot of the flyers that talk about support groups that we have in the area. They'll have that and then we'll email it out too.
They also, so I put one of your flyers that has all these listed down.
Yeah.
There as well.
Okay, so yeah, there are local activities like support groups that are available, whether that's to you as a caregiver by yourself, or also if you want to come with the person that you're caring for. All's Connected, I mentioned earlier, and that is, it's in essence a social networking website that is for anyone affected by dementia. So you can reach out and interact with other caregivers. And then also online, the Alzheimer's Association website, I do not envy who takes care of it because it has so much information. And so if you have a question, again, call that helpline or go to the website and you're gonna be able to find just a host of resources. This top website, alls.org/care, that has a lot of caregiver specific resources. And so I'm sorry, we are a couple minutes over, but I hope that was informative. If you have any questions, I would be happy to attempt to answer them or otherwise throw them at Meredith. But thank you for coming today. I hope not just this presentation, but everything was helpful.
Regina wanted to share one quick resource that she forgot to mention that's really important, so.
Yes, so in your pathways, guys, on page 43 and 44, there is a resource to help you with those advanced care directives that we were talking about. This is a company called Honor My Decisions, and it is a digital way to do that so that, you may have your paper copy at home, but if an emergency happens, this is something that you can access from your phone. There is typically a charge for this service, but if you look on page 44, down here at the bottom, Celeste Robinson is my supervisor. She's the aging director. If you email her and ask her for an Honor My Decisions activation code, she will give you that so that you can go on and prepare this with your for yourself and for your loved one. And it's on page 44. She just has to give you that code and you can go on and do that. So if you're interested, please give her an email. Thank you.
All right, well, you guys made it. Thank you for sitting through. I know this was a lot in a short amount of time, but we really appreciate you coming. I hope it was helpful. Myself, Meredith, Regina, we're all available if you have questions now, or most of you should have our emails and some documentation that has been given to you in a folder. Feel free to reach back out as well, and we'd be happy to help any way that we can.
Can we ask you, what is it, would it be in essence a clinical question, and then you get back with us with an answer, or how do we go about it?
I can try.
Yeah. Well, I'm not talking about asking you now, I don't want to hold things up, but I mean, if I could send you an email and ask you some of the questions, I made notes up here, can you help me?
I can
pursue
probably
answers on that?
pass it on to Dr. Wojcicki, who would probably be able to respond.
Thank you.
All right, well, that's the end. So thank you so much for coming.
Thank you.
So, and there are books on the table, the Dignified Life, those are free for you to take. If you'd like one, if you're online and would like one, just put it in the chat and we'll get it in the mail to you.
Thank you.
So
Thank you.
you're welcome.
Thanks. Yeah, I don't ask the question. They see it, you say,